个是新病人，好，55岁的一个小姐。So this is a new patient. This is a 55-year-old female, and this is her pleura effusion specimen. We've seen this specimen yesterday, so it shows metastatic adenocarcinoma. Whenever we encounter the new patient, we will do a cell block and to perform TTF1 for the confirmation of primary lung origin. So the tumor is diffusely positive for TTF1, and we can use the same cell block specimen for subsequent EGFR mutation analysis. So this is the urine cytology specimen. This is a washing urine performed by the ureteroscope, and the location is left renal pelvis. So for the washing cytology specimen, it is much more often that you will encounter cellular cluster instead of individual dissociative cell, because we use some force to flush the urothelium, so the epithelium will fall down in a cluster. So in a cluster urothelial cell, sometimes it's a little bit difficult to appreciate the individual cell morphology because it's all in cluster and it can be really three-dimensional. If we take a look of the background actually shows some inflammation, which is not normal in upper urinary tract cytology, because these locations should not be any inflammation. There must be something cause the inflammation. It could be just urothelial tract infection, or it could be obstruction resulting in retention of the urine and subsequent inflammation. So here we see some inflammatory cells. Some cells seems quite degenerated. Could be necrotic debris, but it is uncertain. The cell over here, you see the periphery of the cell. Usually we will see more like umbrella morphology with much lower NC ratio. But here you see some increased NC ratio even at the most peripheral part of the cell cluster, which is a little bit unusual. And here we see some more hyperchromatic cells. So I have to say the morphology is not easy to appreciate because majority of the cell seems to be more three-dimensional, but the background is quite dirty. So it is a little bit unusual. So I was thinking about a typical suspicious, and the patient have a concurrent biopsy, and the biopsy was signed out as high-grade urothelial carcinoma at the same location, which is left renal pelvis. So you can appreciate that this hyperchromatic, irregular nuclear membrane, some coarse chromatin pattern, a little bit degenerated, but still increase of NC ratio. So I think it's quite reasonable that this represent the same lesion. So it's better than we can go to like more loosely cohesive area to appreciate that individual cell morphology to be more definite. So this is high-grade urothelial carcinoma, but it's coming from the upper urinary tract. So the next specimen is pretty much similar. It's also a upper tract urine washing cytology. So in this specimen, the previous specimen, it showed much more hemorrhage. So you see a lot of RBC in the background. But this specimen is much easier to interpret. We don't really need the biopsies to confirm that it is a high-grade urothelial carcinoma. So here you see very typical, like increased NC ratio. And you can use the reference cells, like the inflammatory cell over here, to demonstrate that this is indeed in large nuclei, very prominent increase of NC ratio. The chromatin pattern is not very hyperchromated. It's a little bit like a ground glass or pale, but indeed you can appreciate some coarse chromatin inside the nucleus. So this is more like a less frequent feature of the chromatin pattern. We call it hypochromasia instead of hyperchromasia. But it is also an unusual pattern of the chromatin like staining. So this is definitely high-grade urothelial carcinoma. So we see individual cell, which is much more easy to appreciate. And here are some more. And here you see individual cell necrosis. So this is much more easier than to call these high-grade urothelial because you cannot see anything from this very tight three-dimensional cluster. But the dissociated cell is very like diagnostic. And in this specimen, we can also see a lot of individual cell necrosis. So this is a high-grade urothelial carcinoma from the upper tract. In this cluster, because when we do the washing cytology, we wash the entire collecting like epithelium. So here is we think is a benign umbrella cell morphology with lower NC ratio, more cytoplasm, and with a umbrella shape at the periphery of these clusters. So this is a benign urothelial cluster with well-oriented umbrella cells at the surface. So this is benign. But this is not benign. You didn't see umbrella cell, right? You see only the high NC ratio cell at the periphery. So this is positive for high-grade urothelial carcinoma. Okay, the next specimen is a 'pleural effusion from an 80-year-old male. On low power, you might not see anything suspicious because you didn't see a cluster of cells, three-dimensional like arrangement. The specimen is hypercellular, but majority of the cells are individual cells, like loosely associated with each other. The screener called the specimen negative, but when we go on high power, this cell looks quite bizarre, even though they have relatively bland nucleus. We see a lot of cells with eccentric nuclei and with quite foamy, bubbly cytoplasm. And you can see majority of the cells looks like this. This is very unusual. This looks like signaling ring cells. So you can appreciate that it seems to be that most of the cells are individual signaling ring cells. So it looks like a positive signaling ring cell carcinoma instead of negative. So these are not mesothelial cells. Mesothelial cells supposed to have centrally located nucleus. This is all eccentric, so this is not mesothelial cells. So if we take a look of the cell block, it is more apparent that these are all signaling ring cells. This is from the pleural effusion. So the first differential diagnosis would be metastatic gastric cancer to the pleural cavity. So the requisition sheet, it doesn't say very clearly. We have to check the history. And he just recently, just a couple of days before, had a biopsy of the gastric. There is a small ulcer, but it was proven to be positive for adenocarcinoma. So this is a metastatic pleural effusion with typical morphology of gastric sigmoid cell carcinoma. So we call this positive. The disease burden is quite high for this case. So the next specimen is from the ascites. So the patient had a past history of pancreas adenocarcinoma. In this specimen, we see inflammatory background, and we also see some cell cluster. So this is suspicious on low power because we see cohesive cell cluster. And then we go on higher power. This is typical, like ductal features of well-differentiated pancreas adenocarcinoma. The nucleus is not very atypia, and we don't see prominent nucleoli, but this three-dimensional tight cluster plus the typical like a ductal arrangement, this is positive for adenocarcinoma, and is likely a well-differentiated pancreatobiliary morphology. So this is compatible with the patient's past history. So this one is not so difficult. The next specimen is from the CSF. The patient had a past history of breast cancer. So for CSF specimen, usually we won't see any cell. Just a little bit of cell could be problematic. So here, usually the specimen is very scant, the cellularity is very low, but we see like two individual cells with enlarged nuclei. We don't have the reference cell here, but we can compare the arrow, so which is indeed enlarged with higher NC ratio. This is a typical morphology for metastatic carcinoma in the CSF specimen. So here you see some more cluster, maybe a little bit so-called Indian fire arrangement with Y line on in a straight line to each other. So this is positive, and this is positive for carcinoma and compatible with breast cancer. So for the CSF specimen, we need to go to higher power and to check if there is any nucleus present in the specimen. So the next specimen is from the pleura effusion. So here, we also see some like classic tight cluster suggests that it's metastatic disease, most likely adenocarcinoma. And we go on higher power. Indeed, it has a glandular arrangement. The cell has vesicular chromatin and with polymorphism, and some did show like a cherry red nucleoli. So the patient has ovarian cancer history. So this is a metastatic ovarian cancer to the pleura cavity. And the disease burden is also high. The primary histotype is serous carcinoma. So the next specimen is an ascites specimen. This one is also not very easy to identify. The patient had the history of hepatic cholangiocarcinoma, which is adenocarcinoma arising from the bile duct. So it has similar pancreatobiliary morphology, which could be really bland looking. So the detailed sign is that you need to identify cluster of cell with three-dimensional, and even though the nucleus doesn't look very atypical, this is unusual. So this is a ductal arrangement with three-dimensional cells. The patient has liver biopsy and approved that there is a cholangiocarcinoma. So without any like a confirmed history, if this is the first specimen, I think to be safe, we will call the specimen suspicious only. But if the patient has confirmed to have a intrahepatic cholangiocarcinoma, and the image demonstrate in this patient peritoneum like a nodularity, which suggests that pleura seeding, and this is positive. So we can safely call this because of the clinical presentation, and the patient has already been confirmed with the history of cholangiocarcinoma. So this is not very easy because when you appreciate the nucleus in this cluster, the feature is very subtle comparing to the adjacent cells. You only see a little bit of irregular of nuclear membrane and overlapping, which is quite prominent. And also a little bit of pleomorphism. Some cells is a little bit enlarged, some is smaller, but overall the nuclear feature is relatively low grade. But if you take a look of the adjacent cell, this could be a histiocyte. You see the membrane is very smooth. The chromatin is very like a uniform, delicate, instead of a little bit like irregular chromatin pattern over here. So this is adenocarcinoma. So the pancreatobiliary adeno sometimes very difficult to make definite call. So let's move to the aspiration specimen. The first specimen is from a parotid gland of a 44-year-old female. So this is a liquid-based preparation, BD short pass preparation. And this is a very cellular aspirate. We see a lot of cell, mostly in cluster. And at low power, we can appreciate there are some like branching ductal-like structure. So in this specimen, I would say the most diagnostic view would be over here. So let's get on higher power. So this is a chunk of chondromyxoid matrix with like a tiny oval shape or stellate shaped cell inside this matrix. This is very typical for pleomorphic adenoma. So for pleomorphic adenoma, we want to see this type of chondromyxoid matrix, but sometimes it is not very easy to see, especially for the sampling reason in cellular pleomorphic adenoma. Sometimes we won't sample the stromal component. We only sample the cellular myoepithelial component, which is just like this here. So this is like a big chunk of myoepithelial cells. If we go on high power, you can see the cell has a short oval shape, short spindle, like oval shape, and the matrix is not so apparent. So the pleomorphic adenoma, we want to see three components: chondromyxoid matrix, cellular myoepithelial component, as well as ductal component. So here, we do have some ductal cell with a nice ductal arrangement over here. So here is also. So I think this is a pleomorphic adenoma, and we can safely call this benign, even though there's very scant chondromyxoid stroma. So for the pleomorphic adenoma, especially the cellular one, we need to screen for like every part of the specimen to make sure there is no high-grade component to exclude carcinoma X pleomorphic adenoma. So this is a typical cellular pleomorphic adenoma case. For the pleomorphic adenoma, this is the direct smear. For the GIMSA type staining, or what we perform here is loose stain, we would like to see this type of fibrillary, like a magenta color matrix closely intermingled with the myoepithelial cells. So this is very typical for pleomorphic adenoma. So in this specimen, the stroma is very, very scant. Very scant. But we can still definitely see some stroma. So this is a benign pleomorphic adenoma, which is the most common salivary gland neoplasm that we see in our practice. The next specimen is also from parotid. It's a 60-year-old male who smoked one pack of cigarette for more than 40 years. So on low power, you see large fragment of oncocytic epithelium with nice honeycombing arrangement. And in the background, you can see some degenerative like debris and inflammatory cells. So this is very typical for a Warthin tumor. And we have a lot of epithelium this time. It is not very common to see these many fragments of oncocyte. So we see degenerative debris, we see oncocyte, we see inflammatory background. This is a typical case for Warthin tumor. So this is a Warthin tumor. So let's move to the pap smear. First is a 45-year-old female. So on low power, it's a little bit inflammation. We see nice superficial cell and intermediate cells. So the background seems to be normal. So what we want to do is to identify if there is any precursor lesion or microorganism. So here you see a superficial cell, a more like pinpoint shaped nuclei. Next to it is an intermediate cell. The nuclei will be slightly enlarged. And here you see there is a markedly enlarged nuclei with a vague halo at the perinuclear area. So this looks like a vague koilocyte. The halo doesn't have very rigid contour yet, but this looks like a vague koilocyte. So for this cell, we would say probably ascus is okay, but we need to find more cells in these specimens. So usually we will go through the direction of the smear to search for more. So here you see also a vague koilocyte over here. And here is more apparent. It's a cluster of koilocytic cells, and the contour of the halo is more rigid, and you can appreciate there are some increased NC ratio as well. So I think for this specimen, it is okay to call it a low seal specimen. So here we have some more. Because a lot of these type of legional cells, and we see some even with binucleation, and this specimen is diagnostic for low seal, and we didn't see any other like high-grade atypical cell in this specimen. The next specimen is relatively uncommon. It's a 74-year-old female. She has total hysterectomy due to unknown reason. So the patient has already removed her uterus, and she has some symptom, and there is a biopsy of a vagina suggests that she had a high-grade carcinoma, likely clear cell carcinoma. So this is her pap smear. So this is not a cervical smear. It is a vagina smear because the patient already has total hysterectomy. In this specimen, we see a lot of very hyperchromatic cells, like scattered around the entire pap smear, which is unusual. For this pattern, usually we would think this is due to direct sampling of the lesion. So the lesion must be located at the vagina, which is the sampling site. So here it is adenocarcinoma, high grade, without question. And in the background, the cell show naked nucleus, so suggesting that the cell membrane, the cytoplasm, is very fragile. From the smearing effect, it is very easy to get a naked nuclei. So clear cell carcinoma can have very fragile, like a cell membrane cytoplasm. So in this specimen, we know we have a carcinoma, and it is likely located at the vagina, which is the sampling area. Hence, that we get tons of carcinoma cells in this specimen. So we call this positive carcinoma. And because the patient already got a biopsy, so it is compatible with the biopsy, the diagnosis. So the next specimen is even more rare, and this one is very important. So particularly the trainee and the screener, it's unusual to see this in the past smear, but we have to remember the presentation. So this is from a 67-year-old female who had a watery vagina discharge in the recent weeks. So she came to our outpatient department. So the pap smear is not very cellular. By morphology, you see only these intermediate cells with a higher NC ratio. So you know this is coming from a more atrophy type. The patient with higher age, it's a more atrophy type. This is much more like immature metaplastic, like a squamous cell. So it's compatible with the age because the patient is already 67, already post-menopause. So this is an atrophic smear. And at the periphery, we've seen some mucinous like a background with slight like orange color in the background. So they definitely show some mucin, but the color and the feature of this mucin is very unusual. Here we have a tight cluster of glandular cells. So this is definitely glandular cells. So if we move these to a body fluid specimen, you will think about this is pancreatobiliary, right? The cytoplasmic, like a mucin, had the oranginophilic feature. This is typical for a gastric type mucin. So there is no gastric type mucin in the normal cervix. The cervical mucin is not oranginophilic. It's usually more like gray or a little bit bluish, but not oranginophilic. So this type of mucin is unusual in the cervix. So this is not normal. This is definitely not normal. In addition to this only slight small like cluster of glandular cell, in the background, we see a lot of, this is degenerated mucocytes with also intracytoplasmic like a oranginophilic mucin. This is also unusual, which suggests that the cervical glandular component may undergo gastric metaplasia. So they were legion of endocervical gastric metaplasia. I forgot the name, which is lobular something hyperplasia, which is the precursor of the gastric type adenocarcinoma of the cervix, which is a HPV independent like malignancy of the cervix. In this area, this is what Dr. Lai used to call ileocondyl type debris background. So in here, you see markedly degenerative mucocyte with chorioretic nucleus and with a slightly a little bit like a dirty background. So this is so-called what we call ileocondyl type like mucin background. So I think there is a lesion in the cervix which is related to the metaplasia, particularly gastric type metaplasia. It could be hyperplasia. We didn't see any like more atypical cells, but it could also be so-called gastric type adenocarcinoma. And oftentimes it has a very low-grade morphology. In the old time, we call the adenoma malignant or minimal deviation adenocarcinoma. So this is definitely requires some further investigation. So for this case, we call this AGC, and I think to urge the clinician to do a biopsy, because sometimes cervical biopsy we cannot make diagnosis because the cytology just so bland looking. So I think it's better to call this case as AGC favored neoplasm. So we see some atypical glandular cell, even though it is very bland looking, it is atypical here, definitely atypical here. In addition, we see the ileocondyl like mucophages or like a degenerating mucocyte in the background. This is also unusual. So we call it a typical glandular cell favored neoplasm. And we make note that it has a gastric type mucin feature, so which suggesting it could be a glandular lesion with gastric type metaplasia. It could be hyperplasia or it could be a gastric adenocarcinoma. So this is quite uncommon, but this is a very important finding that everyone should know. Okay, so this is for today.
Thank you.
So for pap smear in Philippines, do you do the direct smear or do you do liquid-based cytology?